Alrighty, can everybody hear me okay?
I can.
Perfect. All right, so thank you everybody for joining on to our webinar. We do have Dr. Michael Rigas here today, going to be presenting for us on understanding IVIG. Just a little bit about myself. My name is Alexis Alpori, and I am the current president of NEOMED's student chapter of the National Association of Specialty Pharmacy. So generally, when it comes to specialty pharmacy and IVIG, we would be trying to monitor patients and going through their patient plans and their care plans, and filling those prescriptions for them and trying to get the insurance coverage. So Dr. Rigas is going to go through some insurance issues with IVIG, reimbursement structures, things like that, and some different preparations and a bunch of other things. So tune in to listen to what he has to talk about. I'm very happy that he's here today to present for us, and I'm going to let him take the stage.
Well, thank you, Alexis. Can you hear me okay?
I can.
All right, and can you see me okay? I have my camera turned on, but it's not on the screen here, so not that anybody cares what I look like, but just so you know I'm alive and well.
Yeah, I can see you, and I also can see the presentation, so you're good.
Okay, good. All right, so good afternoon. It's afternoon here in California, evening there in Ohio, so I'm happy to be here with you, and I'd like to thank AAIDA, that is Lauren Dunlap, who's on the phone with us right now, is the president of AAIDA, and Alexis for working together and then inviting me to be part of this. I see the date, I had October 21 on here because that's when we first started to do this, but it's obviously November. So first I'd like to thank everybody, and I'd like to let you know this is my first lecture that I've done for pharmacy students not in the state of California. So I lecture at UC San Francisco, UC San Diego, USC, Western University School of Pharmacy, Chapman University School of Pharmacy, and one other one. I think there's 5 total. I don't know if I did 5 or not. But anyway, so this is the first one out of the state of California. So I'd like to welcome all of our out-of-state students and hope that their pharmacy career is going to be good. As you can see, I just retired from being the chief clinical officer and co-founder of a company called Kava Fusion. And we're going to talk about that in a minute and its impact on IVIG. But first, I think I want to divide the talk into 3 parts. First, I want to tell you what's happened to me in my career so that you can either avoid what happened to me or emulate it or at least be aware of it. And then second, we want to talk about what Kava Fusion does as a specialty infusion pharmacy. And then third, we're going to start talking about IVIG. And it may be that there may be not enough time, to get through everything. So like I just did for UC San Diego, I talked to a second-year class last week or 2 weeks ago. I had an hour and a half. That wasn't enough. So we did another hour for interested students. That was last night or Monday night. And then we probably going to have a third hour for those students who are still interested next week because there's so many questions about the economics of it all. So let me start off by moving the slide here.
Mike, right quick, I just wanted to interject here that our attendees can ask you live questions by typing in their questions to the right in the box over there, and we're going to have a time towards the end to be able to get those answered. So you are able to, the attendees are able to interact with you in live time as well. I just wanted to.
Okay, I see the comment coming in there. So we already talked about AAIDA, and that is a group that's founded by Lauren, and she's a patient herself. And I met her about a year ago, I guess, through a mutual friend. And I'm happy to be part of this group that's helping patients. The thing I've done most so far with AAIDA is give lectures about IVIG and other issues, as well as to help several AAIDA-connected patients who could not afford their high-cost IVIG or other biologic therapy. As through this career, I became an unwilling pharmacoeconomic expert, even though I thought I would be pharmacodynamic or clinical expert to begin with, but you can't do one without the other. So let me continue down with the slides. I'm going to make sure I can advance them properly. So here's the goals. We want to talk a little bit about the breadth and width of pharmacy's careers as experienced by me, so that will help you as a student see options that you may want to explore. When I talk about FDA approved diagnosis for IVIG, understand the cost of therapy to the payer, understand the cost of therapy to the patient, and be aware of the impact of multiple IVIG formulations available on you, the patient, and the payer, and on the pharmacist here, and then be aware of the impact of manufacturer shortages and payer formularies. And so these are all very high-level goals that I'm hoping we can achieve. And by the time we're done, I'm back to my student teaching. The students should know the answer to these questions. Why is FDA approval for such disparate diseases for IVIG? What is the definition of specialty pharmacy? Why does it cost so much? Why is it so much work for an MD office and pharmacy to get IVIG therapy authorized? And why is there so much difference in how insurance companies pay for IVIG, comparing government payers like Medicaid and Medicare to managed care companies like Blue Cross and Aetna, things like that. So these are some of the things we want to cover today. And these are things I think that have resonated well with other schools of pharmacy, and if there's anything unique or different anybody wants to talk about today, I'm happy to entertain anything else or deeper into this if you want. So let's first talk about what happened to me. I was thinking I wanted to go to medical school, but my grades were not good enough. I got accepted to USC School of Pharmacy, and I ended up doing a residency at UCSF Hospital Pharmacy, and I applied to several other residencies, and specifically did not apply to USC. That's University of Southern California, not University of South Carolina for some folks that may think that. So I didn't apply to USC because I wanted to go someplace different. And of course, it turned out that UCSF was a very renowned place then and still is. It was a great experience being there with the people who wrote most of the books that I used in pharmacy school. So that led to a job at Queen of the Valley Hospital, which is here in suburban Los Angeles County. And I was the lead and the chief and the director of clinical pharmacist position. That was what I had there. I worked there for 6 years. That led me to get offered to come to a hospital, another one closer to home, to be the director of the clinical pharmacy program. That led to being director of pharmacy of Valley Community Hospital, which is a 100-bed acute. And when I got there and was fully in charge, it was in a city about 200 miles north of Los Angeles, out in the country, and it was a very interesting experience. I had to do everything from scratch. There was no unit dose system there in 1990. They never had a clinical pharmacist there. No one had ever been on code blue. No one had ever done a gentamicin consult. No one ever did a pain consult. No one ever did a TPN consult. And it was quite an interesting experience there, starting everything from scratch. So I wanted to buy my first new car, and my wife in 1992 said, you need to make more money. So I got a job being an on-call pharmacist for Option Care, which is my first experience with home infusion. That led to me being offered a full-time job there. That started in 1992. That was a small privately owned franchise in Central California. And that led me to my first experience with home infusion. And there I did a lot of pain control, making all kinds of narcotics and other things from scratch, making them from powder and sterilizing them myself. That led to becoming more of an expert in TPN and antibiotics and chemo. And I had several doctors that I helped start their practices of chemotherapy or pain control by making all the drugs for them. We sold that Option Care, and I became the VP of Apria for the Central Coast of California, and that led to the VP of Apria for the whole country a few years later. So that was in 1998. And that experience was very useful because I now was at my first nationwide position where I was responsible for 40 pharmacies in 22 states, about 1,000 employees, and about $200 million a year in revenue. So that was a pretty big step up, both in responsibility and pay and skill. That led me to leave Apria when it sold all of its pharmacies in California. The company that bought them in California was called Crescent Healthcare, and it was a nationwide infusion company that was privately owned. And they bought all of Apria's pharmacies in California in 2002, and I went over to work with them and be the Senior VP of Clinical Affairs And you can see we had 10 pharmacies in 2 states. And this is the first time that I worked for a company that did not do DME or respiratory. And my boss was the CEO, and I was basically number 2 in command of this company. And so it was quite an interesting experience. Eventually, that company got sold, and I got an offer to go to Geisinger Health System, which is nearby you in Pennsylvania. I was there doing a consulting job, and we liked each other. So I got offered to be the Chief Innovation Officer for Pharmaceutical Care. They had 10 pharmacies in Pennsylvania. They had outpatient revenue about 50 million and system revenue for about 4 billion. And that position, I was represented, I oversaw all the pharmacies in the outpatient system and was a consultant to all the inpatient pharmacies and all the medical practices on neurology, neurosurgery, endocrinology, rheumatology, etc. So whenever one of those departments had a problem with their high-cost biologics, Epogen, Neupogen, Remicade, Tysabri, whatever it was, I would get a call and go there and try to help them figure out how to make the overall system better, the inpatient system as well as the outpatient and all these outpatient pharmacies. So an amazing experience, except I never grew up. I mean, I spent my whole life by the beach in LA, so I wasn't too keen on Pennsylvania summers and winters. So that led to me and my former partners from Crescent deciding to found Kava Fusion in 2010. And we now have 21 pharmacies nationwide and doing about 400 million in revenue. They have about 10,000 or 11,000 patients getting service every night in 44 states. So I was the second employee of that company, and we had no pharmacies, no offices, no patients, no contracts, no revenues, and a lot of expenses. So after 10 or 11 years of that, I had probably made 20 infusion pharmacies from scratch, the clean room and the whole office, and started each one of those, either bought another pharmacy and converted it or made one from scratch. And now I'm retired from that company, and I'm consulting with them still, several other companies, as well as several patient support organizations like AAIDA. And once I met Lauren, I realized, after 40 years of being a pharmacist, what did I learn? And so I really want to help people and form people as patients and doctors. And I really want to help them, as well as pharmacy students, better understand the high-cost biologic world, especially the world of outpatient high-cost infusion therapy that is not self-injectable. So that's a complex concept, but that would include Remicade, Tysabri, IVIG, probably 30, 40 other drugs that all are going to wind up costing the patient or the insurance company more than $100,000 a year, and maybe the patient $10,000 a year out of pocket. So I know we said there's going to be questions afterward, but I don't know, does anybody want to talk about ask any of these particular, sometimes people want to ask me, what was it like how did you like being the employer versus the employee? How did you like being employee versus being owner? How did you like hospital versus home infusion? So I don't know if anybody is interested in any more depth of those questions, but I think it's important to see what happened to somebody. And one thing, if I go to the next slide, here's the sort of pearls. And if I see any questions pop up, I'll answer them. So each job was a great experience in its own right. Only the first job was by an advertised position, and that was before the internet, so that was in a newspaper, amazingly enough. All the other ones were due to contacts or connections. So every other job I had, somehow somebody learned about what I was doing. I created a name for myself, and whoever that person was thought or told somebody else, and that somebody else thought that I could help them with their problems at their hospital or home infusion company. Each job built on my past experiences that related to solving the problem. Almost every company I went to, except the one we just founded from scratch, there was a lot of things wrong with it, and my first duties were to focus on what's wrong and fix it. As I became more seasoned, I had more bargaining power. I remember my first job, and you all may laugh, and I can't hear you laughing. My first salary was $16.32 an hour as the chief clinical pharmacist at Queen of the Valley Hospital in 1982. So I thought I was in the megabucks then, and I learned rapidly that that wasn't megabucks, and obviously the bargaining power helped a lot each time I could bargain for higher pay at each job I went to. My USC and UC San Francisco training were good starting credentials, and everywhere I went, when anybody asked me where I went to school or what I learned or how I trained, pretty much there were no questions asked about this. And I'm sure in your local area, in the upper Midwest or even east of the Mississippi, your pharmacy school credentials are going to stand you in good shape too. My hard work and desire to impress with clinical skills verified the school's credentials. That is, when I told them where I went, then they expected more of me. One guy I remember meeting, he said, we never hired a PharmD from UCSF before, and something like he thought we were like guided missiles that could go off course anytime. So I had to really focus on what I was doing and not trying to get in too many different things when I was going on code blues and gentamicin consults and kinetic consults. And in this hospital here at the Queen of the Valley, they had never had a clinical pharmacist before. So, and the pharmacy was closed at night, so the nurse manager did everything, and I had a lot of work to do in the morning. But they started calling me at night saying, we have a car accident coming in, can you come and mix the antibiotics? We have people in surgery, we need pain control. And of course, I was trained to never say no. So pretty soon I was working 8 to 6 and then coming home, eating dinner and going back 2 or 3 times a night to solve all the problems that came up. And then even doing gentamicin or other things by telephone in the middle of the night when they would call me and say something was going on there. So it was a great experience. And that led to the next job and the next job. And even now, 40 years later, 30 years later, whatever it is, when somebody asks me about something, I can usually go toe to toe with any doctor, whether it's endocrinology, neurology, immunology. The only thing I don't really have a good handle on these days or ever had was pediatrics. But so I think the training and this last bullet here, I had to change with the time and keep up clinically and business-wise for the past 40 years to stay on top of my game. This has been a lot of work. I joke that at the number of hours that I worked over the 40-year career was typically at least 60 a week, sometimes more than that, especially when we owned our own companies and when I thought or somehow believed that I could save money by me doing more and paying somebody less to do something else. So that is what's happened to me so far in 40 years. My son is a pharmacist. He runs a home infusion, a specialty pharmacy in San Diego. My daughter is a dentist, and she has oral maxillofacial surgery, and she is crazy, I think, and she just started medical school this summer. She wants to get the MD DDS, so she wants to be the highest level of oral maxillofacial surgeon there can be. So good luck to her. So any questions about what happened to me, either how did it happen, why did it happen, or what would I do different? Do I like being the employer, the employee? Anybody want to ask any of those kind of questions? Otherwise, I'll move on. Okay, I see no questions. Can you guys all hear me still? I can't see anybody out there, so I suppose you're all there and doing okay.
Yeah, there's no questions yet, but I'll keep track of them as we go along, okay. And then we can. All
right. It's a little bit hard to pace when you can't see everybody's response. So all right, so let's switch gears and let's talk about. I want to talk about home infusion for a few minutes and then specifically focus on IVIG for the rest of the time. So many people in pharmacy school, at the ones I teach at, they don't know what home infusion is. Many of them don't know how to mix IV drugs, and many of them have never worked in a pharmacy that is not retail in a CVS-like setting. So I'm going to talk at that level, and I'm sorry, I'll try to zip through it so we don't waste too much time, but these are the kind of therapies we do. And the acute therapies, they're called acute because we never know about the patient until this morning, typically, or the same day. They're all discharged from the hospital, and they all need to start therapy the same day at home. And usually they stay on for weeks to months, although some TPN patients, some enteral patients could be on therapy for life or much longer, like 6 to 12 months. Whereas chronic therapies like IVIG and sub-Q immunoglobulin, Remicade, Tysabri, and other disease state modifiers, or most of the other not self-injected, but infused specialty medications, they're chronic therapies by definition. That means when we get the referral, it may take us days or weeks or longer to get the therapy authorized. And once the patient starts, they're typically on it for the rest of their life. So the definition of a specialty pharmacy, in my mind, is that the drug requires specialty purchasing, specialty clinical management, specialty insurance company management, specialty mixing or distribution, and then specialty nursing services to infuse it at home, or has to be taught the patient how to do it themselves. So, and also typically is more than $600 to $1,000 a month at cost. So these drugs, antibiotic, TPN, their TPN we usually bill around $6,000 a month in the home setting for a standard 3-liter TPN. Antibiotics can vary anywhere from $1,500 to $3,000 to $4,000 a month, depending on what antibiotic it is. Enteral's typically about $1,000 a month. Chemo can be very cheap if it's 5-FU, very expensive if it's just platinum or something else. Hydration is typically only like $1,000 a month, and pain management can be $1,000 to $3,000 a month, depending on whether we're using morphine or Dilantin or methadone or something else. So these are the acute therapies, and then the chronic therapies. An average IVIG patient that is immune deficient, needs IVIG as replacement therapy, that's typically about 50 grams a month, and that results in a bill of around $100,000 a year to the insurance company. And if you're an autoimmune or a muscular patient, that dose is typically bigger, results in about $200,000 a year to the insurance company. And then Remicade, Tysabri, others, Remicade is about a couple $1,000s a month, and Tysabri about $3,000, $4,000 a month. So these are big ticket items, and there's a lot of scrutiny from the insurance company trying to avoid pain, so they don't authorize them easily. And they know that, like for the acute therapies, they know if they don't authorize, the patient will stay in the hospital longer, and that will cost them more money than the outpatient acute therapy typically. But for the chronic therapies, they're not in the hospital typically, and when they go home, the insurance company, once they agree to something, that's pretty much going to go for the rest of the life of the patient or a long time. So they really want to make sure they approve and have all the proper roadblocks in their mind to keep these bills down. So this is what a state-of-the-art clean room looks like that we make. This is a modular clean room, and this one you can see has no hoods in it. So these HEPA filters are in the ceiling here, and there you can't see them very well in the picture, but every 4 feet there's one around, and this room is shaped like an L, and there are stainless steel tables, and the HEPA filter blows clean air in between the wall and the plexiglass curtain, and then this becomes one giant clean hood basically all the way around and all the way up to the right side of this room that you can't see here. And also to the right of this, there's a pass-through window over here, and they can either bring the drugs in to the anteroom and then in here in a cart that would be sterilized, and multiple patients can be sent in to be mixed at the same time, or a single or a few patients can have their stuff put in a box and put into the clean air, into the clean room using the pass-through window, which can't be opened on both sides at the same time. So if you open the door and put something in, then you close the door, then the pharmacist or tech can open on the inside so that no contamination occurs. So these rooms, as I said, I've built about 25 of them now, and they are a modular. You can see these are 4-foot wide plastic and extruded aluminum panels, and the actual airflow in some of the panels, like this one, actually goes through the window and up. It sucks the air out of down here and goes up into the top, and where it mixes, and with the big air compressor and everything is over here that runs everything. So we make some of these square, we make some bigger, we make some littler. This one is around 30 feet long and 15 feet wide. And so, and this cost roughly, the clean room itself costs about $200,000 to make and put in place. Can be removed and disassembled and removed and put to a different place. But every time we've tried to do that, we've run into obstacles that we didn't anticipate. So not a very high yield return on trying to move it to a new building. So let's talk about our business model. So we're specialty infusion, clinical management, and distribution to the alternate site setting. That's what we think we do for a living. So we love to mix. We're pharmacists, and we made the company in our vision, and all of us love to mix. So that's the whole point of the company. We believe if we treat the patient right, the finances will follow, and people will start to like what we do. And alternate site setting for us is mostly home, but can include infusion centers, nursing homes, and other places. We have done several patients in a car or a hotel because that's where they were living at the time, some patients on a cruise, and some patients in different different countries. So currently, we have about 1,000 pharmacists and nurses, techs, and billing and supportive staff in 16 states. And we have patients, like I said, about 10,000 patients every day getting service in 44 states. So what's not showing here is that we also have about 1,000 licenses that I was responsible for between boards of pharmacy, boards of nursing, the state, the tax board, for the pharmacy, the pharmacist, the tech, and the nurses, as well as business licenses and alarm licenses and all kinds of crazy things that you would need to run the business. And then what's not showing here also is just about 1,000 payer contracts that we need so we can bill the payer, but whoever that payer is in whatever one of those 44 states. So we started this company from scratch. No pharmacists, no pharmacies, no contracts, no licenses, no revenue, no patients, and no employees. So this was quite a experience in my lifetime, and I expect that everybody that has any entrepreneurial spirit would want to start some kind of business of their own sometime in their life. I happen to be around 55 years old when we started doing this. I recommend doing it younger. When I was like 35 and 45, I had staff and I was already in the executive management of various places, so I didn't have to do all the work, the executive management work and the real work of a pharmacist. But when we made this company, I was doing the mixing, I was doing the delivery, I was emptying the trash, I was cleaning the clean room and all that stuff when we first started the therapy, the company. So now, as far as the business model goes, we buy direct from several wholesalers via several GPOs, group purchasing organizations. And the biggest challenge, as you can imagine, right now we're buying around, we're buying about $200 million a year of IVIG. And we're using about 1/50th of the whole country's output of IVIG. And so I, of course, never thought I would be involved in such an organization that had so much impact on patients' lives. But from a business standpoint, the challenges in matching supply and demand with reasonable, this is cost of goods, how much do you pay for the drug, reasonable, how soon do I have to pay for it versus how soon do I get paid from the insurance company. And if you're not really, if you don't have a lot of bargaining power, which we didn't at the beginning, we had to pay for the drug in 30 days, and we typically didn't get paid for the drug from the insurance company for 60 or 90 days. So we were in effect a bank to start with, which is very painful. We also tried to do just-in-time availability. That is, we order every day for the acute drugs, and we kept maybe a couple of weeks of supply of IVIG in stock all the time. And sometimes that was enough, sometimes it wasn't. Sometimes we want to stock up because of price increases that were coming. So the just-in-time availability is an important concept to either embrace and do, or to not embrace and do when you feel there's a better reason to buy more, either to get a savings or if you think a shortage is coming, or if you just can't deal with having to deal with that much inventory all the time coming and going. And then product selection, you know, our doctors, our hospitals, our insurance companies all have formularies, if you will. Even the insurance company calls it that doctors like certain drugs and patients like certain drugs if they've already had it before. So that means we have to know what our customers want and make sure we have it. So once we've gone through the work of meeting the doctor, meeting the insurance company, getting the contract, doing all the preparatory work, then we want to make sure we don't have to call back and say, gee, we're sorry, we don't have that drug, we don't have that contract, something else that is going to cause all the work we did to generate that business to be not to not be able to work. And in this case, I like to use the analogy, even though I'm not a hunter and I'm not a hunting advocate, but if you're hunting or fishing, you need to get a license, you need to get the equipment, you need to get to where the animals or fish are, then you need to have good luck. And in the IVIG or IV business that we're in, all these things, the cost of goods, the payment term, the licenses, the permits, the buildings, the insurance contracts, all those things are what you need to be ready to go, but you still have to meet the doctors, meet the insurance companies, and have all the things and have them know you. Otherwise, you're just sitting there in your pharmacy hoping for business and doesn't come if you don't know all those people and aren't moving and shaking. So one last comment is these processes could be improved if we could better align the interest. But right now, I'll show you a slide in a minute. The drug maker, it typically has their own issues in mind, and many of them do not include the patient or the pharmacy. They're mostly thinking about life cycle of the product, how much we're getting, how much are we selling, and where do we get our raw materials from? Do we have shortages? Do we have FDA recalls? And we have the physician. Many cases, the physician has an idea what he or she wants for the drug therapy, but most of the orders we get are either wrong or improvable. By about 50% of them are either wrong, the wrong drug, the wrong route, wrong dose, or they are improvable because there's a better drug, route, or dose, or labs, or a drug that's going to have less of an outpatient cost to the patient possible. And then the patient comes along, and because they talk to their friends and they go on social media and they look on Google, about half of the patients never heard of the disease they have before and never heard of the drug they're prescribed. And about half of them have heard of both and are very picky about what they want or what they think they want, which can be difficult to match the need with the insurance company's formulary or the patient's out-of-pocket cost. And the payer, as we already talked about, the payer is trying to optimize its business and not really, even though they say they're for the patient, they say they're trying to help, but most cases it doesn't appear that way. Okay, I'm getting a note here. The organizer stopped sharing her webcam. All right. So then, and finally, the government is supposed to protect patients from unscrupulous drug companies, unscrupulous payers, and unscrupulous pharmacies and pharmacists. And they do their best, but obviously, the government is not very efficient, and we'll see in a minute how it can get in and make things very difficult for us, or at least if not difficult, it makes things that are constantly changing that we have to be responding to. So just a quick, how does it work? We get a referral from the doctor that includes demographics, a physician order, patient's clinical information from the hospital or from previous outpatient tests. We get insurance authorization. We look at initial benefit to see, does the patient have a benefit that they can use at home or hospital or outpatient hospital or doctor's office? And then we give them a welcome call, and we talk about what the insurance is going to pay, what their out-of-pocket is. Have they ever had this kind of drug before? Do they need help with affording their part of it? Is there anybody at home to help them learn how to do it or infuse it with them or for them? And then once we've cleared all that stuff up, that leads to the patient care. We actually schedule, we ship the medication supplies, we manage reauthorization when it's needed. The nurse goes and does the infusion, and then re-shipping occurs every week or every month, depending on what the therapy is. And then we manage the refills accordingly. And refills are typically, as I said, every week, every month, and reauth may last the whole course of antibiotic therapy, a month or so or two, or it may only last 6 months and have to be done twice a year for an IVIG patient or TPN patient. So more pharmacist logic here. We're looking for a diagnosis that is the physician able to support the diagnosis that they have given, because that's really what causes the insurance company to agree to pay. We look at the physician notes, we can look at laboratory tests. We understand what the insurance IVIG policy and authorization criteria is. We identify other treatment options if they don't have the right benefit of those contraindications. And then we have to highlight the severity of the condition, because otherwise the insurance company may seek to delay the therapy and think that the patient will not, sorry, somehow my camera turned off here. Let me turn it back on again. Okay, so And then over here, there are several approved compendia that the insurance company may use in order to decide whether they want to pay for something or not. And you can see a great diversity of things that may be very old. It could be updated every year. It could be something that each insurance company may only use one thing or another. But typically, our intake staff and our billing team, they know each insurance company's policies, and we have them printed. And if somebody came along for IVIG and they were immune deficient, we would immediately go to, say, Blue Cross of Ohio. We have it on file already. We'd see what the criteria is, and we'd know whether or not the data given to us by the doctor was going to meet that criteria and would be supported and approved by the insurance company. If not, then we would contact the doctor for more information and I think the next slide here, if it doesn't get approved, then we would go to a denial process where we try to figure out why it was denied. We try to figure out what to do about it, and we would do all the work for the doctor to shield him or her from trying to come up with a plan. And we develop the appropriate plan of care that would measure the patient progress as well as getting the therapy authorized. We pick the right brand of IVIG that is consistent with the drug insurance company's goals and their budget and their formulary, but also that is right clinically for the patient and right for the patient as far as their out-of-pocket cost, if that's an important concept. We make recommendations to manage infusion-related side effects. We follow up and report to the physician and payer after every sequence of dosing for an IVIG, if that's 3 days in a row. We would provide progress notes, either electronically or by fax or by whether we can get into the patient's EMR or not. And we coordinate between providers. That would be between the pharmacist, the nursing agency, the physician, the lab, and in many cases, the insurance company wants to know what's happening as well. So the plan of care involves initial consult. We establish the goals, and we set up expectations so the patient knows what's going to happen. Here we talk about drug information and how it works, the side effect storage. We talk about risk versus benefit of using IV versus sub-Q, reduce frequency and how to avoid infections, how to increase their strength and function, since most of the patients we have either immune deficient with IVIG or autoimmune, some neuropathy, and usually strength and function and quality of life are their biggest issues. And we talk about what the nursing is going to do and how frequent. So these are all things the patient needs to know about. And as we said, many patients have never had IVIG before. So if we have adverse effects, we start off planning to avoid them by having the proper infusion rate for that patient's disease state and other diseases. We ensure adequate hydration. We do pre-medication with very minor things. And if there's still problems, we can change the route of administration from IV to sub-Q in many patients if the incidence of side effects and adverse reaction during infusion, we think we can limit it or control it by the route by changing to sub-Q, depending on the side effects they're seeing. So we coordinate all these things, the venous access, the infusion rate, the equipment, the med storage, the patient comorbidities, the allergies, and of course, as we said, patients want special requests. I like this kind of tubing. I want this kind of tape. I want this kind of fanny pack or pump. I saw this on TV. My friend has this. You know, there can be a lot of things that the patient's going to request. And this is very different than a hospital setting, because usually in the hospital, the pharmacist and tech are providing the drug, giving some consultation. But in the home infusion, if any of these things go wrong, it's our company that suffers either our reputation, our relationship with that doctor, or patient or legal repercussions can occur. We have physicians that are consultants with us, infectious disease, neurology, dermatology, whatever, but none of them run the company with us. So this, one of the beauties of home infusion that I see is pharmacy is in complete control of the company, and it is the highest level of function of pharmacy that I know. It is much more exciting, but many things can go wrong, both financially, clinically, and philosophically between you and your patient and doctor. Now going directly to the IVIG, if there's no questions, we'll spend the rest of the time talking about IVIG. So FDA approved indications currently are these ones. There's about 25 primary immune deficient approved indications, and there are about 10, as you can see, ITP, chronic lymphocytic leukemia, bone marrow, HIV kids, Kawasaki, CIDP, and MMN. Now, this is critically important because there are about 140 other primary immune deficient diseases that aren't approved by the FDA to be treated with IVIG. And there are probably 200 to 400 other non-primary immune deficient diseases that are not approved by the FDA to be given and treated with IVIG. So there are many times more non-FDA approved possible uses for IVIG than there are FDA approved uses. And you know, in America, as long as it's approved for something, the doctor can use it for anything he or she wants, but they have full responsibility for the outcome, of course. So I'll come back to why this is so important in a minute. Let's talk about how do we make IVIG. We collect it as far as plasma, and we have two kinds. When people are paid to donate, it's called source. And right now there's about 460 collection centers in America, up from 380 that were there around 2018 or so. And you can see they get paid a nominal amount for, and I see there's a question blinking here. I'll start wrapping up between 7:45. Okay, I can see that we have a couple of minutes. Okay, let me move that out of the way. All right, so, and then recovered is where it's voluntarily donated. So you can imagine it takes about a year from the time the blood is donated to the time IVIG is available to be sold to the public. And it is often supply constrained, especially during COVID pandemic time. There was about 20 to 40% less donation of blood than there was before. So many companies are using stockpiled supplies of IVIG to keep up with the current demand. So we still may see a shortage. So the process dynamics are complex. If you think of a barrel of oil, you've got a pretty good view of IVIG. You can get albumin, IVIG, hemophilia, and other specialized biologics. So it's very much like a barrel of oil with gasoline and diesel and jet fuel, and they're trying to sell everything at the highest price. So it is complex, that process dynamics of making it. Within the last few minutes, what we'll do is I have a listing here, and I'll make this available to Alexis. This is a listing. Can you see my screen, Alexis, that I changed screens now?
Yes, I can.
Okay, this comes from Managed Health Associates, and this is one of our GPOs, and this is the October 2020. I'm expecting to get the October 2021 version anytime. So I'm gonna make it a little bit bigger so you can see it. Let me get rid of this on the side, make it a little bit bigger. And so this lists all the 10% products here first, and these are all the 10% products available in America right now. Then as I go down, these are all the 5% or lyophilized products, powders, and then below that, these are all the ones that are FDA approved to be given subcutaneous. Some of them are only subcutaneous, and some are the same IV approved formula that we saw above that is also approved for sub-Q. But in this case, you can see the ones that are IV approved as well. They're only 10%. And therefore they're about half as strong as the Hizentra and the Cuvitru and Cutaquig, which is 16.5%, and Zembify, which is 20%. So if you're going to give something sub-Q, for most patients, the more concentrated, the better. But for some other patients who already got Gamma-Ched or Gamma-Nex or Gamma-Guard liquid in a 10% form IV to start with, many of those patients want to switch to the same drug sub-Q, and therefore they can. It just means the volume is going to be higher. So I will go back to the top and just zoom in on a couple of things, and then we'll stop for questions. And I will offer you a second, if anybody's interested, a second hour to talk about the pharmacoeconomics of IVIG, which is equally complicated and we have contained in this deck. So the first thing is it tells us who makes it, and I'm just going to make it big enough so you can see it. And we'll just look at the few. Like the first one, Gamma-Guard liquid here, made by Takeda. It's FDA approved for primary immune deficiency and MMN. It has a nominal amount of IgA and If somebody is IgA deficient, we know that in the labs before we started, and we wouldn't want to give something that is high IgA containing. Depending how IgA deficient they are, they could get anaphylaxis. So the product we'll see down here, GammaGuard SD, or we can see this product over here, GammaPlex, at only 20 microgram per mil. We can use either one of those for somebody who is profoundly IgA deficient, where most are higher. You can see these are 100 microgram per mil. So we wouldn't want to use one of those, might have an increased risk of reaction. We can see the osmolality, almost all are in the 350 or so range, which is isosmotic, except for this one, which is really off the market. So osmolality is not a big issue because they're all isosmotic. The stabilizers, none of them are considered to be a real sugar. There used to be, there were several products that had real sugar that caused problems with kidneys, like sucrose. That's pretty much out of anything now. So stabilizers, not a big deal. Sodium content is very minimal. Typically, that's not a big deal for most patients. The pH, everything is almost all in the right pH, so there's really no, it's listed here, but it's never a concern. The half-life, everything has got about a 1 month half-life, so that's not a concern. The viral safety process, most companies have up to 3 or 4 steps, and each step does a 10 to the 9th reduction in the viral load, and these multiple steps are additive. So most companies now have a 10 to the minus 27th reduction in viral load by using 3 10 to the minus 9 reductions in a row, and one company over here actually does 4, then they have possibly a 10 to the minus 36 reduction of viral load. But it can be safe to say that no patient in America has gotten an infection, a viral infection from an IVIG product since this was all put into place around 20 years ago. It tells you next which ones are FDA approved for subcutaneous. Those are on the list at the bottom. Then the doses are usually listed after that. And then below that is the rates and things, and those vary. And typically they're very similar. And then the storage and half-life, most often it's good for a year at room temperature and up to 2 or 3 years at refrigerator temperature. So, and then the same listing of information is for the 5% and lyophilized products. And just to note, this only lyophilized products left is GammaGuard SD, and you can see it comes as a powder. When you make it in still water per injection, if you make a 10% solution, its osmolality is 1250, which is more than 3 times normal, and therefore can cause significant issues. So there's something to be aware of. The only product left, this one here that is also a powder, is now off the market, but still people stocking and using it, and it hasn't totally gone away yet. You can see it has the same problem here. So let me stop there. I'm going to offer, as I said, to go meet with anybody who wants to meet and go over the rest of the presentation. I'll show you what's left here. There is a whole rest of the talk, about another 10 slides about the pharmacology and reimbursement issues. And obviously we don't have time left for that right now. So let me stop there and ask if there's questions. So Alexis, I'm turning it back over to you as the end of our first hour.
All right, so it looks like we have a question. What was your biggest obstacle in becoming successful in your career?
That's a good question. Early on, I thought if I was just clinical, that would be enough. And in my second hospital job, or third hospital job, I realized that the CFO, Chief Financial Officer, and other financial people were always on me for how much money I was spending on drugs and pharmacist salary. So I learned rapidly that being just clinical was not enough. And what I didn't list here is I began to get a master's degree in healthcare administration. My kids were babies, or maybe less than 10 or whatever at the time. And I learned a lot every day. Every class I took, I did it remotely. But I never finished it because my kids grew up and wouldn't go to bed on time, and I could never finish the last 2 classes. But I learned so much, and I think the biggest obstacle for me was to learn that being clinical alone or being business alone, in my opinion, is not enough. You have to understand economics, especially when IV drugs are so expensive and when they last so long in these patients' whole life. So I think the second half of this talk, when we talk about the business aspect and the economics of IVIG, I think that's where people are going to see the real situation of IVIG and other expensive drugs. So that did that answer your question, Alexis?
Yeah, I believe so. I mean, it wasn't my question, so hopefully it answered that question. Let's see. Our next one is, how did you choose which doctors to reach out to when you first started your business?
Well, when we first started Cabo Fusion, we knew a lot of doctors from our previous Crescent Healthcare business. That we, even though we were out of business for 3 years, when we came back, we had a list of all the neurologists that we knew and a list of all the neurologists in California and various states that we wanted to attack. And we got lists of doctors from the American Neurological Society and other groups like that. And we also were introduced to various doctors by the people who make IVIG, the IVIG sales reps. And we then met immunologists in the same way. And so we had dinners, we had lunches, we had booths at various meetings. And one of my biggest fun things to do is to meet new doctors and talk about my company and our company and what we could do to help them with their diseases. And based on my past experience and my ability to speak rapidly and talk about all these different diseases and drugs, I was able to make many doctors want to deal with us, more so than most other companies who never had an executive pharmacist who worked for the company to meet with the doctors. Usually it was a staff pharmacist would come, he or she would give a lecture at lunch, and then they'd leave and never talk to them again. Or I would take them to dinner, I would go to their office, I would offer education for them. And by the way, what I didn't say earlier on, when somebody would ask me, when we started Cabo Fusion, why should they talk to me or my company? I would tell them at the time that we did about 5,000 IVIG patients at Crescent and had done about 5 million grams of IVIG. And now when somebody asks me now why they should talk to me or my company, I tell them we've done more than 20,000 IVIG patients in the last 10 years, and more than 20 million grams of IVIG has gone through our company and or administered by me or overseen by me. So that usually gives me the credentials to talk to somebody who wants to listen. So that's kind of a pompous answer, I know, but I think that's important. I think it's a really good thing for pharmacists to think about becoming pleasantly pompous. And I've been described that way before. And that is, I know my stuff. I know that pharmacy is important. I know I can help people. I just have to get somebody to listen to me. And the pleasantly pompous part either gets me in the door or gets me kicked out. Not too often kicked out, but it has in the past caused doctors to rile up against me, but most often I can get them back in the fold. So, so any other questions, Alexis, please go ahead.
Yeah, so kind of meshing two of them together because they basically were the same question. So what resources or financial assistance is available for patients whose insurance does not cover IVIG? So they need IVIG therapy, but they've been denied by insurance. So what resources are available to help these patients?
Okay, I think I have a slide for that. Let me see if I have it here. We'll go on patient issues, patient assistance plan. Okay, so right now, there are several patient assistance plans available from the people who make IVIG. So if you lose your insurance altogether, like got laid off or had to quit because you were sick or something, or too sick to work, many IVIG makers have a program that if you're on their drug before you lost your insurance, they will cover until you get a new job and get new insurance. Sometimes some of those are based on like 720 lifetime grams, which sounds like a lot, but if you're getting 150 grams a month, that doesn't last too long. They also offer other programs that have to do with copay cards that can reduce your monthly out-of-pocket. If you do have insurance, they do offer, as I said, indigent coverage, but it's very limited and usually has to do with having insurance before that and losing it somehow, becoming newly indigent as opposed to being indigent to begin with. So there's also many foundation-based, and these would be nonprofit organizations, and they get money from the drug companies, and these foundations can then make it based on disease state specific. So you could apply to them and say, you know, I have multiple sclerosis, or I have immune deficiency, I can't work, and I can't afford my out-of-pocket. Maybe I'm on Medicare, Medicaid, and these foundation-based many of them are very tech savvy. They'll actually give us a credit card we can apply the patient's copays to, or they will even have electronic online adjudication. Every time we bill the insurance company, a supplemental bill goes to them, and they pay, say, $400 or $500 every time we dispense the drug that the patient would normally pay. And then there are infusion pharmacy sponsored program, like at our company. I oversaw our financial assistance plan for the last 5 years and created it to begin with, where if I can't, like if I have a patient that owes $20,000 a year, and maybe I can get $5,000 from the foundation to apply to them, and then maybe I can get, if they live in New Jersey or New York, maybe I can get $2,000 from the state of New York, and then maybe what's left is $8,000, and I can see if they can apply to that for our company. And depending on the drug, the dose, insurance company, the patient's financials, all that could result in me be able to combine a Cava Fusion-based discount, an IVIG maker discount, and a foundation, and even maybe a state of New Jersey discount. So that all could come together to help a single patient. But you can imagine how much work that must be to coordinate all that. It may take several weeks or even a month or more to put it all together. So it can be very stressful for the patient and the pharmacy and the doctor. And then it can take a lot of work to get it covered like that. So I think that's the answer to your question, Alexis.
Yes, thank you. And I do have one last question. This is actually a question of my own. So, when it comes to IVIG or the subcutaneous IG, do you notice that insurances prefer one over the other, or is it kind of just the same process? Or I'm not sure how that works.
Okay, well, I can answer that in a couple different ways. So, first of all, if your diagnosis is immune deficient and you need replacement therapy, typically that is 50 grams a month or less, and typically most of those doctors are going to order that drug by the subcutaneous route. So probably more than 80% of all immune deficient patients we've ever had have come with orders for subcutaneous IG to begin with. Now, some of those patients we may have to switch back to IV because their skin is bad or they can't manage it, it's not absorbed properly, whatever. And then the converse is for most non-immune deficient patients, either a CIDP patient or an MMN patient or some other neuromuscular disease, they typically are going to get 110 to 150 grams a month, and that could almost never be given sub-Q, almost always is given IV. So the first hurdle is, what's your disease? And then the second hurdle is, and what is your insurance company? And many managed care insurance companies like Blue Cross and Blue Shield, they don't have a preference, but very, very many of the companies that have a connection to a PBM, and some managed care companies like Blue Cross of California may be connected to Express Scripts PBM or their own PBM. They may want you to go to the PBM to bill the drug, even if it is IV or sub-Q. And then many of those are trying to get the sub-Q to be done on the PBM benefit because they believe it only involves a few nursing visits and the patient becomes self-sufficient, even though all the other complicated things we have to do is still there. So they're trying to push it to the PBM to make the reimbursement NDC number based, and therefore it can be controlled more accurately by them, but that's more of a problem for the pharmacy. So usually it's a split between immune deficient and non-immune deficient, sub-Q, then IV if it's non-immune deficient. Then there's the push from the payer, and then there's the push sometimes that we switch them back and forth because of the side effect incidence can be lessened with sub-Q for some patients, and some sub-Q patients' skin does not tolerate repeated administration of sub-Q, and therefore we have to switch them to IV at their request or our request. So it's a complex situation.
Okay, thank you. Actually, that you ended up answering my other question. My other question was which one's more tolerated, but it seems to be patient-based, depending on side effects.
We did a paper in a publication a couple of years ago, about 200 patients we studied, half IV, half sub-Q. The IV ones had more systemic side effects and less dermatologic or dermatologic side effects, and the sub-Q just had the opposite. much less systemic, but many of them complained about the rashes and welts and things like that that could occur. And if you're using a sub-Q product and you're using maybe 5 needles or 6 needles, you're going to end up with a 2 or 3 inch diameter, ½ inch or ¼ inch high welt every time you do your infusion, and that may take 3 or 4 days to go down. If you're doing the drug Hycuvia, which is really a giant sub-Q dose with a hyaluronic acid to make the tissue come apart easier, you may end up with a 6 inch diameter, like a giant pancake that sticks out almost an inch or 3/4 of an inch as a welt, and that may take several days to go away as well. So the sub-Q can be done by the patient themselves very easily, but there are some anatomical issues, and some people may not like the feeling on the skin. And certainly with the drug Hycuvia, if you're going to try to wear some sort of a bathing suit or something like that, it may not be very attractive to have this big welt showing. So there could be some vanity issues as well as skin integrity and patient management issues all play a role.
Okay, great, thank you. And I actually do have one more question that came in. And is there any difference in cost between the subcutaneous and IV formulations?
Yes, let me just quickly show you the slide again here. So if we look at the IV products, these are all the actual purchase cost for the pharmacy, all of them except for the Ascentive, which is really hospital for kids with Kawasaki disease, so we don't even use that. All these other ones, they're roughly $80 to $95 a gram, depending on how good of a deal you have with your wholesaler or buying direct. Okay, then if we come down here to the sub-Q products, these are IV, the same price, but Hizentra is about $105 a gram, Hycuvia is about $130, Quitaquig about $150, and Cuvitru about $130. So the sub-Q products per gram are typically about 50% more per gram than the IV products, even though you use less grams of those per month. So it's kind of a odd situation where you would think that should be about the same, but they're not. And they used to all be roughly equivalent maybe 5 or 7 years ago. And then as the sub-Q market heated up, these products took off. And when Quitaquig came on the market in 2019 or so, it came in with a $150 a gram price to begin with. And so that really sort of set the stage. So many insurance companies are trying to do as much as they could do to deny or make it difficult to get authorization for sub-Q because they don't like the $150 a gram. Obviously, if we are buying it for $150, we're trying to sell it to the insurance company for AWP minus 15, which could be $220 a gram for some of these drugs. So obviously, the insurance company is going to be pushing back on that. So the purchase price for sub-Q is typically more than IV, and the reimbursement price paid by the insurance company is typically more for sub-Q than IV, and obviously the insurance company doesn't like either of it. So Alexis, did that answer your question?
Yes, it did. Thank you so much. All right, well, it looks like we are about out of time. So yeah, we definitely can have another event if you'd like, where you can speak out and finish the rest of this, because I definitely would like to get more into the pharmacological aspect of it.
Okay.
So I will email you. We can maybe figure out when would be the best time, and then I can reach out to the attendees and see what might be better for them as well.
All right, that'll be fine with me. I'd be looking forward to hearing from you. And if anybody wants to ask me any questions in the meantime, they're either more urgent than that or just want to ask them anyway. If you want to send them to Alexis, she can send them to me and I'll answer them electronically by email.
Is it okay if I share your email with the attendees so they can reach out
sure.
to you?
I mean,
okay.
Yeah, if they want to, just they have to identify themselves. I might not recognize the domain, or it might get stuck in my spam filter. So just in the subject, if you would just put in the acronym for your pharmacy school and say, I forgot what is what is it?
NEOMED, NEOMED.
Okay. All right, so just put NEOMED pharmacy school student question or something like that. Even if it's stuck in the spam filter, I'll be able to see that and separate it out. easily.
Okay. Yeah, no problem.
But
And if it's easier for you, they could always just email me and I can send it to you. That way you don't have a bunch of random emails coming in too.
it's okay. I'm down from my 220 emails a day down to about 15 a day now, so it's much better being retired than it was working.
I'm
So I'm
sure
happy.
that sounds like a lot of emails a day. I can barely handle the amount that I get, let alone
Yeah,
200 a day.
it was out of control, but it was always interesting. So,
Yeah.
and then if we want, we can talk a little bit next time. I don't have any slides, but about accreditation and licensing. So there could be some people that are interested in the regulatory compliance part of home infusion, and I'm happy to talk about that as well, either at the next talk or if anybody wants a separate talk about regulatory compliance as it applies to running pharmacy companies, not bringing new drugs to market, but the actual practical regulatory compliance where we'd actually what you need to make your company stay in business and stay out of jail.
Yeah, that would be great. Maybe we can have two events then. Like, so the next one could be the pharmacological aspect, and then we can have a more regulatory one as well. That'd be awesome. Thank you.
All right. Well, I'll look forward to talking to you or any other students that are on the phone if they want to email. And I'm happy to be established in the state of Ohio right now. I just drove through it on a 5,000-mile motorhome trip through northern Ohio on the way back from Michigan into Indiana about 2 weeks ago. So it was very beautiful as I drove through. So good night, everybody, and I'll talk to you all soon.
Yes, thank you so much for presenting for us and volunteering to educate us about the IVIG. Also, Bryony, one of our attendees, wanted me to thank you on her behalf. So she says thank you.
All
And
right.
thank you everybody that attended for tuning into our presentation. Lauren, thank you for making this presentation possible. It's always a pleasure working with you in our partnership with SASP and AAIDA. And for the audience, oh, go ahead. And then for our audience, if you are interested in learning more, if you enjoyed the webinar, there are more recorded webinars available on AAIDA's website over other topics and different presenters. So if you're interested, go check them out. We also have one from SASP from last semester. Don't watch that one, I presented. No, just kidding. There will be a quick survey after the conclusion of this webinar, so please take a moment to fill it out. It does help AAIDA better serve our community. And then if you are able to, please consider making a tax-deductible donation to AAIDA. Their website is www.godoaida.org, and your contribution does allow them to continue to be a valuable resource for our patients and our medical community. So thank you again, everybody, for attending, and I hope you have a great rest of your night.
Good night, everybody. Bye.
Bye.